So the use of databasing to tackle variance, and the question is, can it do that? Well, the first question to ask is, so if all the clinicians in the room put their hands up, that includes nurses, and now keep your hand up if you routinely database standardized clinical database, clinical information. The rest of you put your hands down. So that's the answer. The answer is that very few people do, and databasing in the UK cannot address variance because we simply don't have the data. So that's a bit of a problem. So for those of you who don't know me, the reason why I get asked to talk about these sort of things is because for the last 25 or more years, we've been doing this databasing in Cardiff. And we have a very rich data source, and we can answer some of these questions. And it's very interesting that a lot of the emphasis is on Bluteq. You've all been discussing Bluteq. We don't have Bluteq in Wales, and I think one of the reasons why we don't have Bluteq in Wales is because we have such a rich data source anyway that all of our data is fairly easily auditable. So we have about 4,000 patients, so interestingly about the same size as Manchester, David, so interesting. And most of those have got MS. And one of the really important things about Wales is you can't go north because it's too mountainous, and you can't go south because you end up in the Bristol Channel. So actually people tend to stay where they are, and you have to pay to get into Wales as well. So people tend to stay where they are. And we know that we've got a very representative population. We pretty much know everybody who has MS in our patch. So 98% or more of prevalent patients. And we have this system which is embedded within the NHS. We have a clinical database which is available through all desktops in Wales, and actually also web-based as well, so you can get it, and actually accessible to the patients now as well, so they can look at their own patient data. And just to give you an example of the richness of the data, we make about 100 new diagnoses a year, which I know is not a huge amount, but we have about 15 to 20,000 patient contacts a year, and Bluteq is catching us up, but we have 33,000 EDSSs as well. So there's a rich data source there over a long period of time, and the average follow-up is, I think, between 11 and 15 years. And parallel to that, we have a biobank as well, which is important. And I think that we should be a little bit more ambitious than just talking about real-world. Everyone's been talking about real-world data and just focusing on EDSS, and I just think that that's wrong. I think we need to be a lot more ambitious. I think that we can do much better than other countries, and other countries are often referred to as the kind of pinnacle of success in real-world data, which has become a greatly trendy thing. Those of you who went to ECTRIMS a few weeks ago will know that about a third of the presentation, it seems, was on real-world data. And I have to say, almost none, I think actually none of those were from the UK. So I guess if we're thinking just to go onto the issue about whether we should be developing real-world data, then I think you do need to think a little bit about what you're trying to achieve if you're trying to inform patient care and to set standards going forward. And so a lot of the data, for instance, that's been presented today and yesterday was all about patients who actually turned up to clinic and who were engaged in the clinical services. And that may not be representative. And there were a number of examples that I recognise as people were talking through their data. So one thing, when you start to produce data and you're going to try and set standards for what you are trying to achieve here, you need to understand who's going to access, who's going to put the data in, and how representative is it? Should this be a population-based study? Should it be clinic-based? Because that's basically what everybody's been talking about. Or should it be intervention-based, that's the Bluteq. You know, you only get the data if you've actually intervened. But actually that belies the fact that maybe 70% of patients in the UK actually have no DMT. So what happens to all of them, and where's the data from that lot? And then think a little bit about the data required. And I'm not going to go into it in great detail, but I think EDSS is a really small component of it. You know, the arguments, all the conversations about being about EDSS, but there's a plethora of other data which is fairly basic that you should be collecting. And I don't think the argument about EDSS should be an excuse to do nothing, which I think it has been used over the last 10 or 20 years. There is an issue about resources, time, and the effort required. I completely get that. But I would point out actually that in our model, actually having that data inputted into almost every new business case for a new member of staff. And so our system has been completely integral in changing the staffing level from me and a nurse when I first arrived to averaging between 25 and 30 people in the MS unit. So that data is completely essential. If you have a handle on your data, you can make the arguments to commissioners, to funders for new members of staff and new resources. But I think that if we did get to the point where there was a collective that was producing this data, then the first thing that should be done should be standard setting. And actually my initial thoughts on this were actually databasing or developing real-world evidence is probably going to increase variance rather than reduce it. But I think that what we really need to do is to standard set. And I'm going to talk just about an example of that and why I think everybody's got in such a pickle about this prescribing variance. So if you look at all of the successful MS registries around the world, they pretty much follow this pattern. This is pretty simplistic. So you have to have in your mind's eye that the reason why you're doing these registers, putting these registers together, is because you want to improve the health of a patient and you want to improve the health of the population with that particular disease. But in order for it to work, you have to have input from patients with MS and you have to have inputs from clinicians. And in order to be able to do that, it only works, for instance, for the clinicians, unless they're academically based and separately funded, if the systems have utility. So if they reduce workload, and there are lots of different ways of doing that, some of which we've incorporated into our system, then actually clinicians will go on using it because it saves time. And if the penalty is doing an EDSS, sorry David, but it might be worth it if you can reduce the effect in other ways. And in order to keep the patients engaged, you have to provide them with feedback. One of the really important issues is to develop external data sources, and you're all talking about the ways in which outcomes should be considered. So mortality was one of them, but mortality is already available in the population census data. We can actually generate that as well. So if you're inventive about the data that you have and you look externally, you can link for other outcomes. So this is what I think we should be aiming for. I don't think we should simply be aiming for a very restricted data set. I think it may be that it might be centre-based or restricted to certain centres, but I think that we need to think along these lines if we're really going to improve population health over the long term. And they would include patient-reported outcomes, clinician-derived data. I think we're very poor at metricising MR data to make informed clinical decisions. We've taken a step of getting whole genome screening on all of our patients now, and we've got a linkage to a Welsh system which provides dynamic demographic information, including all their residences over the last 20 years or so, and we also have a biobank that goes with it. So this is the real-world data situation in the UK at the moment, and we are lagging well behind pretty much any other developed country. But if you were going to choose a place to develop and interpret real-world data, the UK would be it. It's got a big population, which is pretty compact. It's got the highest prevalence of disease in the world, pretty much, and conservatively between 150 and 200 per 100,000. And obviously you know that in the Northern Isles of Scotland it's considerably more than that. And there is arguably an equitable health service that covers the whole country, which is unlike many of the European and other countries around the world. So these are the ones that I know about, and I really apologise if I missed out somebody really important. I'm sure that you all collect data, or some of you do collect data, and so that there are all of these data systems in Plymouth, Liverpool, London, Swansea, the Scottish Incidence Registry, and I noticed there's no, although this says UK here, there isn't really any representation. Is that right, from Scotland, or one? Two, right? And from Northern Ireland? So that's a message there, Gavin. We need representability. And there's the South Wales Registry and Helen leading the Crimson Registry. But actually none of those registries, as far as I'm aware, really talk or combine data effectively to produce answers. So it's not the case that data isn't available. It is the case that we need to work closer together to develop and to standard set for the aims of this particular meeting. So this is just a kind of a warning about, or one of the major problems about starting off real-world data sets in the UK in your particular unit. So this is a graph of the patient contacts over a period of time when we changed from an old system which was based on a very simple database into a web-based system. And it took a long time to sort of get it all started. We had to consolidate it and develop it, and then it took off. So you can see that that's a period of several years before we start to get to the point where we're embedding it in practice and we're getting 2,000 patient contacts a month which are recorded, and they record them because they're utility in the system, and it's quicker to do that than it is to look through a set of notes or write a letter or so forth. And one other point is that we've talked about EDSS a lot, but can we just remember as well that at least in our system, 60% of the patient contacts are from non-neurologists. They collect very valuable information. They're perfectly capable of contributing to this overall picture, and we shouldn't forget that in the process. So what are the barriers to databasing in the UK? And I think importantly, collaboration, which we haven't been particularly good at for the data sets that currently exist. Well, first to say is technology is not a barrier. Okay, there are lots of fancy systems around, but anybody in this room can be taught to put a database together which they could use in clinical practice within a few hours of an afternoon. So technology is not, that's not the barrier. I think what is a barrier in terms of communication is developing common data sets, and you've heard lots about that today, and I'm not going to talk any more about it. I think there is an issue about competitive recruitment and patient fatigue, so there are lots of things that patients are getting recruited to at the moment, and it's difficult to imagine that they're going to produce data for 4 or 5 different studies, and so that's an issue. I think we need to develop a better knowledge of existing databases, and I think we need to be able to work together to develop some of these issues. And we need to have some productivity and feedback for any effort. So as a clinician, I think that I can speak for most clinicians, that most clinicians are happy to provide this kind of data, providing they have an output, and providing they have a relevant output that's going to change clinical practice, and that's not always the case. So the other thing that we have really that we need to take advantage of in the UK is this phenomenal ability, and you've heard a little bit about it, is the external data linkage. And we have this wonderful thing called the NHS number. So if you record the NHS number on your patient, it allows you to link across a number of different platforms. And these are just some of the platforms, and I realise this is slightly parochial because it's our system, but these are the kind of platforms that we've linked to produce informative data, and some of which has significantly changed practice. So the way forward is the last one, so hopefully on time for you, Gavin. So the first thing that we have to do if we're going to be able to produce, if databases are going to influence variance in lots of things, including prescribing, but not just prescribing, is that I think you need to fundamentally change the culture of data collection in the NHS clinics. And you've heard from all of the clinicians, a lot of clinicians here about the challenges. I think that we are still so behind the curve that we haven't actually agreed a common cross-sectional and current status data set, although the AMS register has tried. I think there's nowhere that you can go to in the UK that I know of that has a registry metadata resource. So in other words, where do you go for to say what data is around, what data do people collect on various systems? And that, I think, in itself, if you made that public, if you made that available, then people would provide insights into it that we as clinicians haven't thought about. There's no doubt there needs to be a sustainable funding model, and many of you will know some of the funding issues related to, for instance, the MS registry, and the fact that also in order for registries to be effective, you have to be able to fund them sustainably over many years. So 1 or 2 years is not going to produce the data that you want to change practice. It needs to be a long-term investment. And so you need to provide also some appropriate clinical resources. And I don't think that, I think there's been a kind of a rush to try and get all of this done. You know, people are talking about getting every centre in the UK to do this, and I'm just not sure that that model is successful. It certainly hasn't been successful for the last number of years, and my proposal would be that there would be key reference epidemiology centres who are actually interested and invested in doing these sort of things, who have a sustainable model for developing resources.
Thank you, Neil. Neil? We did try and get people from Northern Ireland.
Did you?
They didn't accept the invitation.
Ask them to talk, that's the thing, and then they can't say no, can they? A bit like me.
So I've actually, Neil McDougall from Lanarkshire, I've actually been the clinical lead of the Scottish MS Register for the last year, and it's quite an interesting experience. It's actually run by the Scottish Government via the NHS Information Services Division, so it's not run by clinicians, it's run by statisticians, data scientists, stuff like that. I'm meant to just do the sort of front piece stuff for it. There's a committee there. We did try to make an attempt to, or I did try to make an attempt to start doing more work with the UK register, but there are data ownership issues. The patients don't consent to be entered into the registry. They're just registered by the nurses at time of diagnosis. And the government ISD service that owns the data is very, very protective of it. Obviously, I'm trying to develop things in the future, but it is quite hard sometimes if a clinician does not own the data to do anything about it. So, again, Scotland's a slightly...
Well, I think you're talking to the issue that I was trying to allude to, is clinicians and patients are essential components of developing information. If you don't develop relevant information, if there's not a product that people can see that they say, okay, well, that makes a difference to the way I approach a patient or to change practice, whatever, then actually the whole thing starts to fizzle out. And I don't think, I mean, it's very good of the Scottish Government to kind of fund this, but you need to have those products in order to make it sustainable. It
is actually a rolling audit of MS nurse services, and it is demonstrating how quickly a nurse sees a patient after diagnosis, and that can be used to feed back to the various NHS boards and just say, you're not good enough, we know you're not good enough, here's a graph, do something about it. And that's what we've done, and we have used it with the MS Trust to get more nurses. It can be used in that manner, but it's limited, and unfortunately it's not necessarily clinical.
It's a good example of how variance actually can drive change. So some variance, if you identify it, is good because you can provide the evidence to